Hello, everyone. Welcome to episode 330 of the Juicebox Podcast. Today's show is incredibly conversational, and I don't want to break it up, so I'm going to put the ads right up front here. Today's guest is David Walton. He's the CEO of T1D Exchange, and I expected to have a more technical conversation with him, I guess, about what T1D Exchange did, but instead we ended up having a multifaceted conversation around type 1 diabetes that I enjoyed so much that by the time it got to an hour and a half, I realized I had to let him go. David and I are going to speak today about the research that T1D Exchange is doing with the COVID-19 virus, and then we get into his diabetes, his life, his management style, concepts about how to help people with type 1. I just really enjoyed talking to David, and I think you'll enjoy listening to him talking to me, and me enjoying talking to him, and I guess hopefully him enjoying talking to me. But that's an assumption on my part because I didn't ask him. Anyway, ads are up front, podcast in the back. What is that, party? What is it? What was that thing people used to say about mullets? Business up front, party in the back? Hey, that doesn't apply to this. This episode of the Juicebox Podcast is sponsored by the Contour Next One blood glucose meter and Touched by Type 1. It's also sponsored by Omnipod and Dexcom. Everyone's got a blood glucose meter. And since you have to have one, you should probably have a great one. And you will if you go to contournext1.com and find out more. The Contour Next One meter is multifaceted, just like this episode. And not just because it can speak to a Contour app on your phone, iPhone or Android, by the way, and help you make sense of the data that's coming back from your meter, but because it's easy to use, easy to handle, has a terrific test strip that will allow second chance testing. Like if you touch the blood, don't get it right, you can go back in without wasting a test strip. But the accuracy of this thing is just otherworldly. Arden's been using it for well over a year now, maybe longer, and it's absolutely the best meter she's ever had as far as accuracy goes and portability. I just love it. Anyway, if you go to contournext1.com, there's a button at the top where you can find out if you're eligible to get the meter for free. And if you're not, you can still have your doctor write you a script for it or pick it up at anywhere, honestly. I guess a pharmacy once people are allowed to go to pharmacies again. Anyway, this meter is worth looking into. contournext1.com. After that, please check out touchedbytype1.org. The people at Touched by Type 1 are dedicated to helping those living with type 1 diabetes to excel, and they have a dance program for children. They actually have a dance studio. You got to go check it out, touchedbytype1.org. If you're interested in finding out more about the Dexcom G6 continuous glucose monitor, you're going to want to go to dexcom.com/juicebox, and to get a free no obligation demo of the Omnipod tubeless insulin pump sent directly to your home, myomnipod.com/juicebox. There are links to all of the advertisers in your show notes, and they're also available at juiceboxpodcast.com. I'm not going to argue with you. You went to Princeton. Is that a burden? By the way, we're recording. And by the way, is that a burden?
No, it's not a burden.
But does everybody say it to you at some point?
I definitely get it once in a while. Interestingly, I have a twin brother, and he went to a good school, Gettysburg College. Mm-hmm. But every time I would go visit him there, it would just be nonstop comments from his friends about, why didn't he go to Princeton, and various jokes and things like that. And then but I once I acted stupid and silly, they realized I was just like everyone else.
Took care of that. Hey, you might be the first person I say this to who genuinely understands what I'm saying. My son goes to Dickinson.
Oh, really?
Yeah.
So. Yeah, I have a friend whose daughter plays basketball there.
Oh, no kidding.
Yeah.
I am probably a 10-minute ride from Princeton University. So you and I overlap a little bit, but that's going to be where that ends educationally, because my son's the bright one, not me. And I think our overlap around education will probably end right around there.
Yeah. I actually live about 25 minutes from Princeton. right now. I'm in Pennsylvania.
Oh, no kidding. I grew up in Bucks County.
In Bucks?
Yeah.
Yeah. I'm in Newtown.
Oh, okay. Oh, so hold on, let's start over. I was born in Newtown. My parents moved into Lower Southampton. We lived there for quite some time. My wife got a job in Manhattan soon after we got married, put us into the Princeton area just to be near the train. And we've kind of stayed since then, but not right in Princeton. If you don't mind walking over some water you've walked over before, how old were you when you were diagnosed?
Well, I was older. I was 24 years old. I was in business school at Penn and noticed these symptoms that ironically I knew about because I had, in my very first job at a college, I worked in a consulting company that did work for pharmaceutical companies, and the DCCT, the Diabetes Control and Complications Trial, had just findings had just been released, and everybody was talking about, we need to do tighter glycemic control. And one of these pharmaceutical companies hired us to help them come up with a program. And we essentially designed like a kind of a, I don't want to say patient compliance program. It was kind of a reward system for people if they did the things that were beneficial, like testing your blood sugar and exercise and so forth. That and it was for type 1 and type 2.
Okay.
This program, but that they would get points. And we developed like a point system and worked with LifeScan, who had the blood glucose monitoring. They were one of the partners. We were talking to gyms, et cetera. So anyway, I did market research and heard from doctors talking about both type 1 and type 2 and the symptoms for newly diagnosed. And so I learned a little bit about it. And then, fast forward 2 years from then, I'd come back for the second semester of my first year, and I'm going to the bathroom more frequently. I can't quench my thirst. I started losing some weight. And I just started dating my now wife like a week prior. Mm-hmm. And I'm telling her this isn't normal. This isn't how I normally am. And ironically, she had worked for Eli Lilly as a sales rep and a managed care rep and sold insulin. So she knew a bit about it. And she didn't come out and say it sounded like it, but I asked some doctors who were also in this healthcare management MBA program about the symptoms. And I said, it sounds like type 1, doesn't it? They said, no, you're too old for type 1. And you're not really a candidate for type 2. So then my vision got blurry, and I went into the student center that day and read off the symptoms to them. And they kind of looked at me and said, well, let's just test your blood sugar,
right,
to be sure. And then I was put in the hospital for a couple of days, and off we go. There was no family history. Although subsequently, I have my sister's son at 3 years old was diagnosed with type 1.
Is that more recently?
That was more recently. And fortunately, my twin brother and I are adopted. Mm-hmm. But we met our biological family when we were 18. So we were adopted at birth. Our parents were teenagers, biological parents. They ended up getting married and then had a son and daughter that are our full-fledged, biological brother and sister. And it's my biological sister whose son got developed type 1. So
I understand.
Clearly we have that genetic predisposition.
Runs through there. You've brought a lot of things up I have to ask you about. So A, and this is just going to be odd, I'm adopted. Wow. B, are your biological brothers and sisters, I don't know how to say this, maybe you're not going to answer it. Did they go to grade schools too?
My twin brother, biological, and grew up with me.
Right.
So he went to Gettysburg. Both my brother and sister went to Florida State. They grew up in Tallahassee, and my sister still lives in Tallahassee. My younger brother, ironically, moved up to Boston. And so he and his wife, and he has 2 kids. They live now out west. And again, T1D Exchange is up in Boston. So I go up to Boston almost every week, mm-hmm. For a few days. And every once in a while I get to see him because he's out in the suburbs. But there's no other family history. There was none prior to my diagnosis.
Right.
Since my diagnosis, just my nephew again at age 3.
Yeah.
So I joke, if you add us together, our ages, you're pretty close to the median age of diagnosis for type 1. But I was a little bit older and he was a little on the younger side. And I know you've got experience with a young child.
I really do.
Yep.
Let me ask you one thing real quick before we move forward. If you're on an Apple computer, right?
Yeah. I turned notifications off on Outlook, but I guess my Yahoo email is.
Don't worry. I know what to do. You're in luck. Okay. The Apple in the top left corner, system preferences.
Okay.
The speaker that says sound. And then under the sound effects tab, alert volume, play sound effects through, drag the alert volume all the way to the left. But leave it open so you remember to drag it back to the right when you're done.
You're saying on the output volume?
Sound effects, not output. So there's sound effects, output, and input. Yep.
I'm on sound. Sound effects.
Sound effects at the top.
Yep.
And then alert volume, there's a slider bar you run all the way to the left.
Got it.
And then that won't happen again.
I'll just keep it off. I don't need to be alerted to that.
You're like, wow, I wish I would have known that years ago.
Exactly. I thought I solved this with turning Outlook off, but my Yahoo emails. Okay.
No, that email really wants you to know that it's there. While we're taking a break, I'm going to have my daughter bolus something. She's downstairs for school. And there. Okay, cool. Well, that's interesting. It has nothing to do with why you're on, but it is really incredibly interesting. And I just picture you in business school trying to impress a new girl, and you're just running to the bathroom constantly. That must have been a big rock to drag up a hill. Like, I'm cool. I swear I am. I got to pee again. I'll be right back.
Yeah. I don't normally go 20 times a day. I'm telling you, this is an aberration.
I swear.
But thankfully, again, we were in a healthcare program, and I was, as casual as you could be about, it happening in the diagnosis after. I mean, I didn't freak out. I kind of tried to attack it rationally, but I was pretty fortunate that I had a little background and I was older, and, I was a college wrestler. So, I was thinking, wow, well, what if this had happened earlier? Like, it would have totally changed probably what I did or how I did it.
Right.
But ironically, in the Penn hospital, I received a call the first day from a woman who I dated prior to dating my now wife. Mm-hmm. And she said, "Hey, I just wanted to let you know, I heard about the diabetes, and if you ever want to talk to someone about it, you can always call me. I know what it's like to live with it." And I said, "What are you talking about? I've never saw you check your blood sugar or give an injection. You have type 1? And she said, "Yeah, I'm pretty private about it." So often would go to the bathroom, and that's where she tested. And, right from the get-go, it kind of gave me an appreciation for the fact that there's a spectrum of how people kind of manage their diabetes, how they think about it. I was diagnosed in a very kind of, let's say, out front manner. People knew, like, why is Dave in the hospital? And and I was older, and it was just a different thing versus, if someone's a teenager or if someone's younger.
You also did like a group thing to figure out if you had it. You were talking to people and asking, because you were around people that you could ask.
They knew about it, and there were physicians that kind of thought, but maybe not, and then just in general, that's often that's often the way I think through things that I don't know. It's like, let me talk to other people who may know information that will be helpful.
Yeah. Well, that's a smart way to figure anything out. I'm now fascinated that you dated a person who had type 1 and you didn't know it. How long were you together?
Less than 2 months.
Oh, okay. Like a college
certainly thing. As you're being interrogated in the hospital. And I think I had every resident, intern, med student, come through, because it's an academic, medical center, teaching hospital. I got asked the same question, any relatives, this, that, or the other. I had several people ask me, to your knowledge, have you been exposed to a virus in the past 6 months?
Oh.
And I said, I don't really have a virus meter. I don't know if I, if I have been or not. But there was one incident with Taco Bell where I was violently sick with a stomach virus that happened a few months ago. That I guess it's possible. I was just attributing it to a bad burrito, but perhaps that was a stomach virus. But then I said, well, is it possible that this woman I dated had a virus and I caught it and I had the same reaction she did? Like, oh, that's crazy. You can't catch diabetes.
Right.
Like, well, I'm not necessarily saying I can catch diabetes. I'm saying, could I catch a virus? And we both had a reaction to a virus that was, this autoimmune thing. And they kind of treated me like I was the dumbest idea they'd ever heard. And granted, it could have nothing to do with it, but there weren't a lot of other great theories they were proposing. So I just figured I'd throw that out there.
I would have told them I went to Princeton. So David, it's only April, but if we give an award this year for the most organic and natural segue, you're going to win, just so you know. Why don't we tell people a little bit about what the T1D Exchange is doing? By the way, I don't know, did we even say that you're the CEO of T1D Exchange? It's not important. It'll be in the title. Anyway, you are. And what are you guys doing right now based around COVID-19?
Sure. So, but first of all, just a very, very high level, we do a lot of kind of what we call real world evidence, doing research and gathering data from things like electronic medical records for people with type 1 diabetes. And the goal is to help improve care, to work collaboratively with HCPs and researchers on that. So we have diabetes centers across the country that participate.
Yeah.
Through that effort, this quality improvement collaborative we have with different centers, this topic came up regarding COVID from some of the researchers to our team that, there's just not a lot known out there. People are, the early information that was coming in, a couple months ago was, diabetes is a risk factor. People with diabetes are getting COVID-19. And as, some of these researchers were looking into what data was really available about type 1 versus just type 2 or overall just having a diabetes diagnosis. There really wasn't much known. And a couple of things came from China and Italy that we saw that suggested type 1 was not a risk factor in and of itself. But that later it seemed some indications that poor blood sugar management are probably more indicative of or have more of a causal role in getting infected or having a severe reaction to the infection. So we said, well, we are set up to gather information from different centers. We're not going to be able to do this automatic kind of pull of data from the electronic medical records of different hospitals. What if we set up a different system to gather data on this from like a survey type tool and have a point person at each one of these centers just document the cases of COVID that have come in and answer we have about 30 questions in this survey that will give us some idea about the symptoms they had, about what their blood sugar control had been previously, what type were they using an insulin pump or CGM, if they were using a BGM, how often were they testing, what medications were they on. And gathering this information, we had a few goals of trying to characterize, does it appear people are being diagnosed in any different rate than either people with type 2 diabetes or just in the general population? If they are being diagnosed, how is it presenting? Is there any pattern to the symptoms? And how is it progressing? What type of outcomes are they having? Are there more instances of DKA for these people? And so the goal was, let's get as many centers as possible. We started with the ones that we work with, which was about 15, but quickly other centers were interested, and we started talking to people at other diabetes centers, and we saw what was going through on ADA websites and newsletters and things. So we've gotten it up now to about 65 centers.
Wow.
And the goal is to get up to 150 to 200 cases documented so that we'll have some ability to draw some insights and conclusions that we can disseminate out, spread to the medical community and to the patient community about, understanding it better. Who knows what some of it is going to be interesting. What do we find? And then others we might try to, confirm some of the thinking that we do have, which is that just having a type 1 diagnosis does not put you at higher risk for getting a COVID infection.
I have to tell you, I'm thrilled to hear that, because a friend of mine who is a physician, by the way, went to Penn. Really, you and I might be friends and we don't know it. He's been on a couple of times through the first 6 weeks of, Corona. We talked very much at the beginning, and then about 3 weeks later, and he'll come back on again as things continue to morph and change. But that really was the consensus, that the best defense for a type 1 against, COVID-19 is being healthy as you can be, and in all the ways that means. And that, he couldn't, early on figure out how someone with type 1 diabetes, just by virtue of having type 1 diabetes, would be more susceptible to it. Anyway, so since you said that, it makes me feel comfortable about what we talked about. No,
absolutely. And there are some other, I've heard Dr. Ann Peters talk, and Dr. Mark Clements, who's at a children's hospital in Kansas City and involved with us. And they've essentially said that's what the research at this point indicates.
Right.
And again, it is possible that as you get more information, maybe we will learn something about a certain segment or slice.
Sure.
We're gathering some other information that could characterize this, but from all what we've seen so far, and we're still early, we haven't analyzed all the, we have about 60 cases documented in the system by clinicians, but we haven't analyzed all that yet. We've just started to do the first 25, and there's a manuscript being written as we speak. Because again, some of it's doing the work and some of it's getting it out there.
Yes.
and helping to disseminate it and provide it so that other people that are looking for it, have access to that knowledge. And I've had a lot of parents that I'm in touch with just in the community where I live, who know that I work in the arena. I've reached out to some proactively, and a couple of others I had some inbound questions, wondering, what the situation is. And that's basically what I've told them. It's like, we'll learn more, but at this point, we don't believe there's a high risk. But the best thing to do is to keep your blood sugar in as tight a control as possible, because we know infections like sugar.
Right.
And if you keep your blood sugar controlled and to the lower side, it likely will help.
Well,
again, I'm not a medical provider, so
no.
But
I have some questions that I don't know if you can tell me from what you've learned so far. Maybe you haven't, but first thing is, about 60 people from about that many locations. Were there hot zones, or was it fairly well spread across the 60? Yeah,
so there's a bit of, when you look at the data coming in, we still have some places with a lot of cases in New York, as an example, that haven't put they joined later to the effort. So they're just going through their administrative process at their center before they submit the cases, but that should be coming within a week or two.
Okay.
Within 2 weeks, we should have 100 cases, I believe. We know that there's one hospital in New York, said that they have about 15 cases, Mount Sinai. But we haven't seen that yet. That was verbal.
You haven't got that data yet.
But they're looking to put that in. But someone had quickly looked to see through their systems, and so they haven't entered that in. But they told us that they think they have 15 cases. Another one, I believe NYU said they may have 8 cases.
Are there some hospitals that are on your list that have not reported back a type 1 case?
Yes, there are some that said we went through and we had no cases.
Gotcha.
So that's what we need to get more of the information. We can't draw conclusions about prevalence from what the numbers that we have, but It is interesting. We've seen, and our centers may have 1,000 type 1 people in that come to their center routinely. So some of them, are decent size. We even have some that are bigger than that are 2,000, or one that's 5,000. So we expect to see some cases, just if you think about general population and whatnot. 1 in 200 people has type 1 diabetes in the US. So,
right. Well, you know what I find doing the podcast, and maybe you know a lot of people with type 1 as well. I see there's two, listen, everything's not black and white, but you meet people with diabetes who are either very just micro about it. They're very on top of it. Their A1Cs are in the 5s. If they get into the 6s, they're, they feel like they've done something extraordinarily wrong, which of course is a little silly, but that's what they're thinking. They're always well within control. And then you'll see other people who, I was just having this conversation with someone last night who asked me, could you interview more people who don't have technology, but who are doing well? And I said, well, that's, subjective, like what is well, first of all. And so the person said, I'm looking for somebody, like you, who's, whose daughter has an A1C in the 5s very consistently. I wanted to hear from someone who doesn't have a CGM, doesn't have a pump and is doing that too. And I said, well, I can try to find someone like that. I said, but you'll never know if they're achieving that A1C through protracted lows. They don't have that data. And also, when I've interviewed a lot of people who don't have, any kind of technology that's moment to moment, and I ask, how are you doing? They always say, oh, I'm doing great. But then they'll very frequently tell me about an A1C that's in the high 7s or in the low 8s. And then I realize that their threshold for what great means, is subjective. And for them, I don't pass out during the day and I'm not dead. My doctor says I'm okay, so I'm great. And it's, there's an interesting swing between, how people manage. And I'm not saying one's better than the other. I'm saying that all those people exist and then they end up in the hospital. It's funny because I think the people who are in tighter control lose some of their control in the hospital. And I think people who are in looser control probably gain better control in the hospital. And I'm wondering if that's being tracked, because you said, what were your blood sugars like prior to being in the hospital? And do you know what I'm getting at?
Yeah, no, a couple of interesting points there you brought up that I could maybe expand on.
Please, because I can't.
We are, we are collecting the most recent A1C, the date and what that was prior to them coming in. So that will give us an indication of where their blood sugar has been, and what their control has been. So that is part of what we endeavor to look at. We'll get something around that, if that role that you mentioned. In terms of the technology, it's funny. I came along this trajectory like anyone else. I mean, I feel like I was in a healthcare MBA program. I was very educated, and I had very good insurance. I worked at J&J for 11 years, and yet in my early part of J&J in the early 2000s. My blood sugar control was not that good. And I was only testing with a blood glucose meter 1.5 times a day. I would test every morning and then either at lunch or dinner. And it was almost, I've never had an endo say anything different. My A1Cs would go between mid 7s to low 8s, but I never broke 7. Mm-hmm. And, I had moved to a new job, new house, kid, you're busy with life. I was just doing injections and using a blood glucose meter. I decided I'd learned a little more, and I'm like, I really should be doing a little better. My endo might say you should test more, but they never said my A1C was a problem or that I could be doing better. Yeah. It kind of suggested if you tested more, it'll be easier to stay in tighter control, which is absolutely true. All the data shows that, but I was a little lackadaisical about it. Mm-hmm. Then I decided I want to go on a pump and see, because I had a friend who was on a pump, and her ex-husband worked for a pump company. So I got on the pump and I saw a little bit of improvement. Still didn't break 7 on an A1C. Then I joined an insulin pump company in 2006. Right. I was at J&J. They acquired Animas. So I went over and I was leading strategic marketing, which was looking at new products and what was going on with competitors and all the emerging technology and clinical data. It was a great, very interesting job. And I to orient myself, I read through some presentations on advanced pumping by John Walsh out in San Diego. And it was a great PowerPoint that went through all the ins and outs of using it. But through that, I realized, wait a minute, they have these formulas for how you dose insulin based on your weight and your total daily dose, and these rules of 1800 and 500, where you divide your total daily dose into those numbers to get your correction factor and your carb, insulin to carb. And I realized mine seemed really out of whack. I was taking 1 unit of insulin for 25 milligrams per deciliter to correct, and I was taking 1 unit of insulin for 15 grams of carbs. That's what the educators put me on when I was diagnosed. Nobody ever looked at that. No one ever suggested that might not be optimal, what have you.
Yeah.
I start reading this presentation and realize that those numbers don't seem to fit with the way big data analysis would ever suggest, or these formulas and clinical studies that were out there would suggest would be in a kind of a stable adult kind of ratio of those factors. So I just changed them on the fly. I looked at my total daily dose, which was like 53 units of insulin that was in my pump. And I divided it in, and I just instantly changed my correction factor to 1 to 35, I think, and my insulin to carb to 1 to 10. And next A1C, 6.8, first time I cracked 7.
Yeah.
So I pointed out that I didn't need necessarily the pump to deliver the insulin, but the pump tracked my total daily dose for me accurately. And all I had to do was go through the history in the pump, and I was able to calculate it.
Yeah.
And that little formula that had been derived from some people, I think down in Atlanta, but it was all over the education and diabetes sources. So for 10 years, I was on the wrong dosing. And it's easier to find issues like that if you're using technology and you're collecting data, and then even have analytics run without you having to do it. Like download reporting now and tools that are out there will do this automatically. But I had I saw great endos. One worked at Stanford, one worked at Novo Nordisk. I had no hypos to speak of, so they weren't really acutely concerned about anything. An A1C of 7.6 for someone with no lows and seems to be doing okay. He's busy. That wasn't, they've got other more problematic situations to deal with, but I wasn't hitting the target, and I had every other thing at my disposal. Great insurance. J&J covered all of our supplies for diabetes. So I had no excuse. Once I got in better control, I'm like, wow, it was positive, that positive reinforcement of, well, now I'm taking the right amount of insulin. And that, and I was frustrated it wasn't brought up sooner, but I was pleased that I finally figured out one of the things that was frustrating me.
Yeah.
So.
No, I'm glad you had that feeling and you weren't angry about it. Cause I've met people who are so angry after they find out that it's hard for them to get past. I've lived my whole life like this, and I heard a podcast, and my A1C went from 8.9 to 6.9 in 3 months. How could nobody have told me that? Sometimes it's hard to get past.
Absolutely. And I also benefited from being around a lot of people with type 1. I picked up some tips then after that. So then it was like sustaining that. My A1Cs just got a little bit better, and then we're consistently at those positive levels. I think because of that education, and then the technology, and then certainly CGM coming out.
Right.
And I think I first tried it in 2007, and it didn't work very well. It was the first gen of Dexcom. But then 2008, when I tried the next one, the 7.
Yep.
And that worked better. Still had some issues, but wow, the insight of seeing how you spike after breakfast, and all the various things that come with CGM. Mm-hmm. One last point on what you just talked about with the hospital, though, because I think that's a very interesting point and it should be pointed out from some of the data that's coming out. And there was a study done by Glytech on just anybody with diabetes or any high blood sugar they saw in the hospital, a pure hospital study, that it's clear if you manage blood sugar and if the healthcare team manages blood sugar more tightly in the hospital, people do better in a lot of scenarios, after surgery, getting out sooner, and if they have diabetes and they were in for some other condition, if you keep their blood sugar in control, they have better outcomes with that other scenario. Mm-hmm. That's not what's happening right now. Because of COVID, there are healthcare teams that understandably are trying to minimize contact with patient and blood sampling, and they're busy and being tapped. The bandwidth is being challenged.
Yeah.
And what this one study showed is that David Klonoff was the author, that that people aren't doing as well. There are a lot of people, and again, this was a lot of type 2 diabetes, but we're certainly interested in the type 1 angle, and we are going to be looking at that potentially with them, and this data that comes in from all these 300 hospitals that they work with. And it's fair to say that there are people that get frustrated when they go to the hospital if they've been managing their diabetes well, type 1, and then they're told they can't use their pump. They can't be doing it themselves. And I know of a number of there are hospitals that will defer to the patient preference if they've been self-managing all this time, and if what they're in for the hospital for is such that they can be lucid and clear in their decision making, then let them keep doing it, because they have been doing a great job 24/7 outside. So why are we going to change that because we're a healthcare team that doesn't know their body as well as they do, and so forth? But that's you can see it's a challenging problem to know what's that threshold for a hospital to say, no, we've got protocols for our quality, and we don't want to get sued if something happens. We have to follow certain rules. And I can understand both sides of that equation. But clearly, I know people that have gone into the hospital and said, I'm keeping my pump. You're going to have to rip it off me. I do a good job with this. I don't want this being mismanaged. Yeah. And to your point, some people might be a little over the top with that, but you understand where they're coming from, because they're a little anxious about what's going on, and they know they can do it. But if they pass out, or if they're given medications that change their thinking, you've got concerns there on the other side. So
yeah, we do a series inside the podcast called Diabetes Pro Tip, and I do it with Jenny Smith, who works at Integrated Diabetes. She's a CDE. She's had type 1 for over 30 years. And I don't even know at this point, there's probably like 20 episodes of it, but we very recently went over emergency room protocols and how to handle yourself during an illness, an injury, or a surgery. Because it's just so, it's not something that would occur to you. You get into a hospital in a position of thinking, well, these people know better than I do, and you just kind of hand yourself over to it. And it's very infrequently with diabetes the case. You're often, the best arbiter of what's going on. And so I think that's incredibly important. Also, I want you to know that when you reached for the word lucid and I did it exactly the same time, it made me feel like I should have tried harder in school.
One thing, my mom, who I grew up with, right? So as I mentioned, I was adopted. She was a voracious reader and a stickler for grammar and vocabulary. Right. And just because she read so much, the words that she would use around the house, some of it I just picked up because I didn't like to read that much. Certainly not. My twin brother and I played sports constantly, and we were typical boys. And sitting down and reading was sometimes, just couldn't be done. Yeah. But I read in school, certainly, and all that. But she's responsible in part for sometimes I would use the SAT words, and then I did some SAT tutoring after college on the side to make a little extra money, and I had to learn extra vocabulary so that I could make sure I knew what I was talking about when I tutored some of these kids, when vocabulary was a bigger deal on the SAT. So it's purely these circumstances that exist sometimes explain things more than any other, innate my grasp of vocabulary is, probably the same as anyone else's.
I got my vocabulary from Howard Stern, so I.
And hence you got into the radio interviewing or podcast.
There are times when I think I'm probably only halfway good at this because of how much of that show I've listened to. There's just I have a timer in my head, and when my timer gets bored, I move it along. And I think that's a helpful thing. Okay, so interesting. I want to kind of just hit one thing, and then I want to ask some more questions. But, I don't know that people think about it, because you get diagnosed and then you're sort of frozen in that time period, right? That happened to you. You were diagnosed. This was the level of care. And then that just became what was. And as the world moves forward around you, your care doesn't always move forward with you. And that makes sense if you're with the same doctor for too long, or you're not around other people with type 1 and you don't say to yourself, like, how come that guy gives himself insulin before we go to the cafeteria and I'm doing it after I eat? Like those small ideas. And we also all sort of sit back traditionally and we wait for the ADA to tell us what our A1C should be, right? That happens historically over time. The ADA says, this is your goal. And then technology gets a little better. And the ADA says, we've done some research. And the problem is the research started 10 years ago and they're rolling up in 2020 and telling you, here's what your A1C should be. But, I did some research too. It was called, I took care of my daughter and figured out how to use insulin. It turns out you can keep your A1C lower if you have a handful of, tricks in a bag that you can use, for the lack of a better term. I call them tools on the podcast usually, but they're just simple ideas around using insulin that keep your blood sugar in a more stable and lower place. And so I understand completely the need for the diligence, looking at data over time to come to a conclusion and tell somebody something. Don't get me wrong. I'm not, I shouldn't be listened to like the ADA should be. Their information is vetted. But that vetting process takes time, where my vetting process is faster, right? It's anecdotal at first, but then eventually it's experiential, and then it's provable. And I'm a firm believer that I think it's nice when people in the diabetes community say things like, your diabetes may vary, and your experiences with diabetes may vary. I don't argue with that, but the way insulin works, that doesn't really vary. That's pretty scientific, and so the way you use it, or what you eat, or your activity level, or all number of other variables could be different. But at its core, and I say it constantly, I don't think I'll ever stop saying it, type 1 diabetes management is about using the right amount of insulin at the right time.
Absolutely.
Right?
I couldn't agree more. And again, I worked at an insulin delivery company, Animas. I mean, what was the point of wearing this pump 24/7? It's to give the insulin in a better way, because if you give insulin in the optimal fashion, you will have great results. Mm-hmm. It's just very hard to do. But if you pick up all of these little tips that and scenarios about the first thing people discovered with CGM, and I heard Dr. Bruce Buckingham mention this at Stanford a lot, was if you once you put CGM on someone, the first thing they realize is how much that oatmeal causes them to spike, and their blood sugar is high for 3 hours afterwards. Yeah. So people start switching to bacon and eggs, like the carbs in the morning when you're insulin resistant. That hyperglycemia contributes, a decent amount to people's kind of above target glucose throughout the day. That dosing formulas that I mentioned, I mean, those, not everybody is going to fall exactly to the formula. It just so happens I do. I'm like literally,
it worked for you.
Right on those, that it fits. And my weight, the amount of insulin I use a day is almost exactly half of my weight in kilograms, mm-hmm. which is what one endo had mentioned to me, that's a good rule of thumb. And it turns out I get pretty good control, in the sixes, mid sixes to high sixes, depending. And now with Control IQ that I use, it's, I'm more in the mids, and I'm not having to, I love that. And we can talk about that later, but that aspect of the dosing, I fall exactly on that. And so I know there are people that don't fall right on that, and that average comes from, a distribution and a number of people. But when you're way off of that average for no good reason, or you're doing a number of things, like it certainly should give someone pause to think, maybe there are some things that aren't tailored to me, that maybe I do need more. And a lot of people don't take enough basal insulin, and so they're putting a lot of insulin to correct for these excursions they have, these highs, that because, if you're not taking enough basal, it's like you've already kind of lost the battle. It's so hard to recover, given how long it takes insulin to work. So
David, you would like this podcast.
Yeah, I definitely agree. But one thing I do want to say about who's able to figure that out on their own, there is this.
It's no one.
Yeah.
It's because life, man, because you're busy living. Here's how I was able to figure it out, right? I don't have type 1. It's for my daughter. And because it's for her, I feel an incredible responsibility, right? And I was and continue to be, to some degree, a stay-at-home dad while she was diagnosed. So I had nothing to do but stare at her and figure it out and go through the real defeating moments and realize, like, I can't let this be her life. Like, I have to figure this out. Like, it must be doable. Some people are doing it, but nobody could explain it. On a side, I got a note yesterday from someone that said, hey, there's someone with an Instagram account ripping off your ideas for the podcast, but trying to put it in their own words. And it's funny. And so I went and looked, and sure enough, it's ripped right out of the podcast, and that's fine, whatever. But my point is that they said it in their words, and it doesn't work that way. And so there's something about my specific experience and who I am and how I communicate with people. I'm telling you, those pro tips, the other day I put a website up for it because people were asking. So I made diabetesprotip.com just so people wouldn't have to, go through the entire podcast if they were just looking for management, because it's interesting. Some people are very interested in community and some people are very interested in management. The community, just regular interviews with people with type 1, and not even like hooked in people, like people you don't know. They don't have a podcast. They're not online. They're just people with type 1. I try really hard to keep those interviews to people like that, right? Those are the most popular podcast episodes. But the people who care about management are fervent about the management. It's interesting how some people want the community and some people want the management. But anyway, I put up this thing just yesterday, and I said, hey, I've got this diabetesprotip.com now. Here's the link. If you could help me in the comments below, just if the podcast has been valuable to you, could you share here? And, so people who are coming on new could figure out what to expect. And I didn't even believe some of this. I'm just looking now. My 4-year-old's A1C is down from 9.7 to 5.9 from the Diabetes Pro Tips. My husband's is down to 5.6. And it goes on and on. It's fascinating. And so I'm proud that I found a way to talk to people about it, because once I could do it, I thought, well, now how do I replicate it for everyone? How do I make it as mass market appeal as possible? The idea of, how we manage. And I just broke it down and kept breaking it down and distilling it until it's just the simplest ideas, so that while you're busy living your life and, you're worried about getting COVID-19 and whether or not you can afford your groceries and how you're going to do at your job and, all the other things that people worry about, when they start noticing a trend up in their blood sugar, that they don't have to go back to a book or go to a doctor's visit. Like what one sentence can you kind of say to yourself that'll bring it back for you? And I tried to do that with all the tools, and I think I have. And it's interesting, when I used to wonder out loud, like, why can't doctors do that? But now I realize that my whole life's been about communicating with people. That's not what a doctor's life is about. Like, they know the idea, and some of them are terrific at it, don't get me wrong, but a lot of them aren't. And, or a lot of them are just like, oh, David's fine. He doesn't pass out. His A1C is not too high. There's bigger problems here in the practice. So I'll go. Well,
I think on the adult side, you find this more. I mean, think about, an adult endocrinologist. How many people with type 2 is he seeing? And, in general, people with type 2 diabetes are not as engaged and don't spend as much of their mind share on their diabetes as those with type 1 do.
Right.
Now, it's obvious with kids. I mean, usually people don't have another condition. If they do, it might be asthma or it might be something else. But diabetes, and with their parents also there, the amount of collective, mind share that's focused on that and the importance of that and so forth, different. So you can imagine these endocrinologists who are just beating their head against the wall because they've got type 2 diabetes patients with multiple chronic diseases. They're not taking their insulin, they're forgetting to take their insulin. They're not taking enough insulin. Their numbers aren't getting any better. Mm-hmm. And then if they're worried about a low, because if, my endocrinologist mentioned this to me, that, when he's had low blood sugars with some of his older patients, it's when he has their adult child ensure that they take their insulin every night. And then they get a low because he's been adjusting their insulin up
based on the
haphazard
way they use it.
The way they use it.
Right.
And so that's part of their skittishness. They're like, because they don't want to, do no harm. They're afraid to give someone something where an older person who's not used to hypo, that's the thing that happens with type 2s. Mm-hmm. That they have many more cardiovascular issues. Heart attacks occur when they're not accustomed to having a low blood sugar, and they end up having it at, when they're 65 to 75 years old. It can be, that can be very dangerous. So having spent some time also in the type 2 space and looking at smart insulin pen caps to try and track that data so we could try to attack that problem, it's a huge problem, and it's overwhelming. And certainly for primary care that's taking care of those, it certainly can be that way.
Well, the percentages, I see them here because there is no more popular type 1 podcast than this one. And I know how many people listen to it versus how many people have type 1 diabetes. And the percentage of people who, are looking for this kind of information is still small compared to how many people have diabetes. There's far more people who fall through cracks for, the reasons you mentioned and many, many more than who are going to have the wherewithal and the drive to figure the rest of it out.
Yeah. Well, interestingly, throughout, I've worked in healthcare for 25 years. And before I was in the diabetes field, I was a consultant working with health plans and with pharmaceutical companies. And I remember looking at segmentation, consumer segmentation, and what are the different kind of types, the behaviors. And a couple of these different analyses show that there's like this 15 to 20% of the population that are the proactive segment. Mm-hmm. They're the ones that are going to go research. They're going to go take control of things. And if you ask them, how do you approach care? Do you research it and then go ask your doctor, or do you wait for your doctor to tell you because they're the trusted healthcare professional, or somewhere in between? And when you look at that, it's 20%, maybe 25, depending, are in that proactive kind of thing. And I saw it in oncology. They saw another company had done this, and the people who are the passengers and people who are the drivers, and then people that are something else. And that, unfortunately, like a lot of the digital health tools and a lot of things that get built for the proactive segment. But we only address that, only that kind of population takes full advantage. It's very hard to get to some of the other people, you have to do more to bring them along that journey, to educate them, et cetera. And this is one of the challenges in healthcare across a number of different conditions, but type 1 diabetes is certainly in that, in that same vein. Yeah. There are, you can go online and look at influencers and so forth, and you see certain profile of people, and they're the ones that have this. They want to share with what they know because they've seen it work, and they're like, why aren't more people doing this, right? But there are a lot of other people just living their life who aren't connected to people. They don't know about things. And so awareness of some of these things, is tough. And like, I've been at dinner tables at a restaurant, and I'm adjusting my pump and telling one of my friends about it. Like, they're asking what I'm doing. And the table next to me, a woman leans over and says, I'm sorry to butt in, but my boyfriend has type 1 and he just doesn't want to listen to me. Could you talk to literally at the dinner table? She's asking me to tell him why he should test more and all this. And so I understand that, and I try to massage the situation. I mean, this guy does not want to be told by a stranger what to do in a public place. That's not the way to handle it. But she cares about him, and she's frustrated she can't make an impact. But people are all over the place, and that's because I did a lot of market research at Animas and surveyed thousands and thousands of people at a time. And, it gave me a real appreciation for that spectrum, just like when I was diagnosed. And I mentioned, the previous ex-girlfriend who took a different approach to her type 1 diabetes than I did once I was diagnosed. And that's perfectly fine. People are different. Right. And, the way people, these different personality types and so forth, it transcends a type 1 diabetes diagnosis. It's not necessarily going to change someone. So understanding that people are different and that different approaches are needed to get people into the education circle.
For me, I realize that everyone's life is going to take a different trajectory, and their level of, how much they want to put into their health on many different fronts is personal. And I'm okay with people making those decisions for themselves as long as they know what their decisions are going to bring. Like, as long as they understand, it's okay with me. I don't know if that makes sense or not, but if you want to get in your car and drive it into a wall, as long as you understand the car is going to, crash into the wall and you're going to die, well, right on, you've got free will. You can do whatever you want. And so I just want them to know how insulin works. I think once you understand how insulin works, then the rest of the things that, quote unquote, are happening to you, you can start to see causality for. And then you can make your own decision. Like, do I want a pre-bolus? I think pre-bolusing knocks a point off of A1C.
It's absolutely. And again, I mentioned that Buckingham comment he made in 2007 at an ADA conference. It just struck me, at the time. And if you were to think about, and we actually came up with a list of these for insulin pumping when I was at Animas. I remember, this concept of so many people say if they just could share what they know, or they wish they knew this earlier, right? So the idea is, well, let's get more people to understand these things. And so the basics of pre-bolus, the basics of how much it should be roughly for the carbs or to correct based off your weight and based off, trial and error sometimes helps you, but you have to get that right. If you're, and I was taking too little insulin for what I ate, and then I was taking too much to correct. Yep. So I had this little yo-yo thing going on, but given that it takes insulin a while to work, and I don't know, 4 hours is probably an average duration. We know some people go 5 or 6, and some might be within 3.5, but that's about as fast as the rapid actings go. Now you have ultra rapid acting, I guess, that can be a little faster. Inhaled insulin that could be certainly faster to bring down high spikes, but that gets, that's like the master's level, like the introductory level you're talking about, having just, hey, if you did a handful of things like the pre-bolus, that right amount, to avoid lows, you did what's necessary, whether that's, if you have a pump, you can do something. If you don't, you're on injections, you do something else by eating.
Right.
But the timing of when you take your long-acting insulin, and there certainly are better ones now than there used to be. So they're more forgiving, but they used to be that you needed to get that right. You couldn't miss the time window too much, or that would be a problem. So you go through it's not a list of 50 things.
No,
right?
Here it is. Your basal has to be right. That's first. If your basal's wrong, nothing else works. And the things you're seeing are ghosts because they're not real. And you don't know if that low, what that's from. When I do a talk in person, and I explain to people that if their basal should be 2 units an hour, but it's a unit an hour, then they're a unit deficient every hour. Then all of a sudden they come along, see a meal. And I always say, like, let's say that God himself has come down, or herself has come down and told you that this is absolutely 60 carbs, and that your carb ratio is 100% right. You can definitely trust it. You count the carbs, you put the insulin in, your blood sugar shoots up. That's because most of your bolus is really just making up for the job that the basal was supposed to be doing. When you say something like that to people, the look of awe on their face is fascinating. Like, why would no one tell me that? And it's because no one knows how to tell you how to adjust your basal insulin. And so I figured out a way to talk about that. And I was like, look, I talk about basal insulin like volume. I'm like, you turn it up until it's as loud as you can stand it. And then if that makes you a little too low, then just turn it down a little bit. If you had a pump, David, and anybody, and your basal insulin was wrong, I could spend a half a day with you and fix your basal insulin.
Yeah.
That's it. It's not hard.
No, I absolutely believe that. And when we, again, design these download reports for clinicians to download the pumps, and then with CGM data as well, I mean, that's often, the ones who are really good and used to doing data interpretation to help patients out, that's the first thing they look for is, are they having lows? If they're not having the lows, then it's let's go. And even if you're having lows, it could be the basal's wrong. But usually people are under basal.
That's
They're
what
not
I find.
Up basal. So to your point, it's the number one thing from a percentage of the time it's wrong. Like, that's where you go first. You have to get that right, because then, like you said, why worry about your attempts at trying to fix, you're bolusing and all of that, the timing and the amount are futile because you've got the wrong background that you can't operate in. So I totally agree.
I practice, not on purpose, but I practice for this podcast by talking to people privately. So try to imagine never meeting someone before, having a phone call with them that lasts less than an hour, and figuring out their issue and pointing them in the right direction, not being able to see anything except for what they're telling you. So you have to learn how to ask the right questions. And then you have to learn how, like, what the path is for them. Like, where do they start? And eventually during that conversation, they'll feel a little emboldened and say, okay, so around my meal. And I always say, no, your meal is all wrong. It's not even worth, I know it's frustrating, but everything you've been staring at, trying to figure out around your meal, it's all meaningless data. It's not real because your basal's so far off. And I said, so you're going to have to forget everything you've seen before and start over again. It's just, I don't know, man. I find it frustrating and uplifting.
No, but what you just mentioned, it brings up two thoughts. First, I just was talking to some people at T1D Exchange about this. We have new people come in. I've started giving a Diabetes 101 presentation that I kind of updated an older one we had and put additional content in there from my experiences in industry and so forth. And it's interesting that oh God, I just lost my train of thought because someone's banging outside my door. You don't hear the banging now.
No, I don't hear the banging. Do you need to get out of the building?
A deck's getting repaired.
Okay. You said you redid the Diabetes 101 that you guys had.
Yeah. So we give that education to everybody about, so they have some baseline understanding about, what's taking place. And one of the things we were talking about, and I mentioned was, people counting carbs incorrectly and bolus calculations. So it turns out there are lots of studies that show that people consistently underdose their bolus insulin.
Yeah.
And the thoughts, and Howard Wolpert, when he was at Joslin, did a nice study with a 30-gram apple and showed most people guessed it was 10 or 20 or 15. And that correlated with having a higher A1C. And the people that saw it at 30 or 35 or 40, which were fewer, their A1C was better. And so the idea was, if you're better at carb count, you're more accurate at carb counting, you're going to have it correlated with a better A1C. Is it causal or is it, who knows? But certainly it makes logical sense that if you're better at that. But the reason people are consistently under is because they have a fear of hypoglycemia. So do they really think it's only 10 or 20, or are they nervous about giving too much insulin and getting a low blood sugar? And so we did some research with an insulin maker about this fear of hypo issue to try to understand some of the aspects of it and the severity and so forth. And we're going to be doing a broader survey and there's some things that we're going to be teasing out. But it does, it brings up that interesting point about there are reasons. Sometimes you can think the answer is we just got to hammer people with carb counting. Let's give them apps. Let's give them flashcards. Let's get a picture of the food they eat and send it to a reference database and tell them what it is. I've seen a couple of these apps that you can scan the photo or scan the food plate, and it will give a reasonable estimate of the carbs. But it turns out people may actually have some intuition about what the number is, but they're down adjusting because they're nervous of that. So that's the first point.
Yep.
The second would be the potential and promise of finally good closed loop systems or hybrid closed loop systems in the market here. Mm-hmm. And I'm a little biased because I use the tandem with the Control IQ, but this promise that we've been hearing about for at least 15 years since I've been working in the diabetes industry.
It's right
here.
They
were talking about closing the loop.
Yeah.
And now some of these issues that do exist, where you could say, is it an education? Can we help people understand this better and train them better on these things? Or can we use technology to handle some of the challenges that just only some people have been able to master themselves?
Right.
Some people just won't. And there's a spectrum there. And the power of this with the time and range that we're seeing with people, and that's the thing I'd point out is my A1Cs haven't improved that much since going on this, but I have no lows. Mm-hmm. So I like zero will be my time and range will have 0. Sometimes I'll have 1%. I used to be at 7 or 8% consistently. And that's to your point in the beginning about there are some people that keep A1Cs down in the 5s, but they've got some real significant low blood sugars at times. I used to have more. I've never passed out. I've never had something that bad, but I've certainly had a lot more lows, and I'd have to, go run and get something to drink and whatnot. That just is much less. And that's because of the technology, night times, being much better. So that whole issue of what are some of those tips, there are tips that you still would need to do even with these kind of systems.
Yep.
But then there are things like overnight control can be drastically improved, because I can't think and do things at 3 a.m. when I'm asleep.
Right.
And the system can.
Yeah. I start off all of my talks by talking about fear first. Like, you have to get rid of your fear of insulin first. It has to be, if you're going to be afraid of this, it's not going to work out. I talk about, when you're asleep, it's a third of every 24 hours, basically. Right. Yeah. So it's free A1C time. Think of it that way, and then, the pre-bolusing and readdressing blood sugars when they don't go the way you want. My daughter's not, low, a scary amount. I mean, everybody has a scary low once in a while, but it's not a monthly occurrence or anything like that. Her A1C is just cemented at 5.5, and she has no diet restrictions at all. Like, we had Chinese food for dinner last night, and then she worked out afterwards. Like, it's not like, it's a regular life. And her A1C has been between 5.2 and 6.2 for 6 years. And it's just doing the things that I talk about on the podcast. It's understanding them. And don't get me wrong, like, after you have some experience with it, it does become second nature. I don't look at an elevated blood sugar for an hour and a half trying to figure out if this is the right one to put another unit on or not. It comes to me pretty quickly. I'm still teaching it to her. But the other part of me believes that closed loop systems are going to keep her from really needing to understand all of the things I understand. And you alluded to it. I'm happy about that as a parent. Like, if my daughter's not the, she's not the sounding board for the rest of the world. She's a person who's going to try to live her life. And if she can live her life without the burden of knowledge about how insulin works that I have, that would make me happy. You know what I mean? And I see it too. Like, it's obviously here, Control IQ's here. Horizon's going to be here before you know it. I'm assuming Medtronic will figure out how to make that other thing work better. And
no, absolutely. The next version of Medtronic will be better. You mentioned that those are 3 closed loop systems, and there are 4 other ones that are in development, and will be out within a couple of years. So that's,
it's super exciting.
The proliferation of these different systems. But, I think the point you made, like, even when you're using these systems, they'll help take over certain issues or problems and make certain things better. But you have to have a base understanding of how it's working and what to do when, oh, wait a sec, I ran out of a supply, or my cartridge, something malfunctioned. I'm getting an alarm here. And they have some technical support, and you can call it. But there are times, where some things have happened where I had to improvise, and understanding what to do, understanding how insulin worked. When I was traveling 5 years ago and had an empty vial of insulin in my carry case, and I went to go fill up my cartridge in my pump and said, oh, I don't have any insulin.
Yeah.
This was at midnight, and places are closed. What am I going to do? And I found a 24-hour pharmacy, and then I go, and they can't get the prescriptions, not on file. So they could give me regular insulin. And so I got a premix, and I just kind of guesstimated what I should do based off of what I knew and how much I knew I took for long acting and short acting. I divided it up, and turns out it worked reasonably well.
That's interesting.
But like, if I couldn't have done that, what a scary thought. If you were by yourself traveling somewhere in a different city and you don't have anything, like, what are you going to do? These things happen. I mean, everyone's going to have a moment of absent-mindedness or forgetfulness, or, unexpected, something came in and changed your plans, and you weren't preparing for that. And, I joked to my wife, going for a walk right after I took a lot of insulin, it's just a walk, but it's amazing how that my blood sugar will go down, and it surprises me every time, and it shouldn't. It's like I'm just walking, but it's insulin, and I play basketball on the weekends, and I lift and work out. I'm relatively active. Walking right after insulin, it's amazing how my blood sugar drops. And certainly when I ran a couple marathons way back when, I learned how to balance the insulin I take, any insulin on board, relative to how long I'm running for, how hot it is. I'm a big guy, so I think it's even more drastic. So I would have to drastically cut back my insulin.
Yeah.
But that was trial and error. That there wasn't a simple formula I could follow. I talked to people who also ran, but I was a little different. And you learn these things, how to tips from other people. So I do think that other people with type 1 can be the best source of information, provided you can kind of take it in the right context. So you learn a tip or two from somebody, but know that someone else responds differently to oatmeal or to steak than I do.
Oh yeah, 100%. Or you'll hear people have to bolus for coffee, and other people don't have to for the
exactly.
caffeine.
I'm one who has to bolus,
right.
And I don't drink Starbucks often, but my kids love it, and I get the sugar free. I get and with that caffeine, and what I have to take 4.5 units if I get a venti macchiato.
Yeah, we've been doing.
But if I drink Diet Coke with caffeine, nothing.
Not a
There's
problem.
Zero impact. So I don't know.
Yeah, some diet sodas make my daughter's blood sugar go up, and I
hear people talk about that, and I drink so much diet soda, and like a lot of people with type 1, and zero impact. I've looked at this, I've watched and see, because people will tell me, "Oh, your body treats diet just like regular." And I say, "Well,
yours
mine
does.
Doesn't.
Yeah,
mine knows the difference."
Right. Yours does. We probably have a half a dozen podcast episodes now about algorithm-based pumping, and there's more and more coming. Because I have to tell you, from my perspective, it's my belief that for the great many people who will never find a podcast like this, or find community, or talk to somebody, or live with another person who has type 1 diabetes and get a tip from them, you're going to slap this algorithm on them, and with hopefully a little bit of guidance, their A1C is going to improve, their lows are going to improve. It's going to make their life better.
Absolutely.
And then there'll be people like me and others that will manipulate the algorithms at times and get it to do more of what we want. And that to me that's the future. Honestly, I would give everyone a Dexcom if I had the power to do it.
Yeah. Well, I certainly I've heard more and more examples now of endocrinologists putting CGM on right away.
Yep.
To people, and after a diagnosis. And it's interesting because I remember this discussion coming up years ago, and people saying, you know what, pumps are put on sooner than CGM a lot of the time, just because they've been around longer and there's more familiarity with them. But as the familiarity has increased and they've gotten simpler and more accurate, that has shifted over the last few years now. So I think if given a choice and you told people you had to have either CGM or a pump, one or the other, you have to choose.
Yeah.
I think most people are going CGM now.
My daughter's been wearing an Omnipod every day since she was 4, and she'll be 16 this summer. And they are sponsors of the show, and I am a huge fan of Omnipod in a million different ways. I know people there, and I know good people who are working behind the scenes. And same with Dexcom. And if you held a gun to my head, I'd give my daughter's pump back. If you made me, if you put me in an either or situation, I'd rather have a CGM.
Yeah, absolutely. And I think, you do have studies like the Diamond study that showed you can do very well with CGM and injections, similarly as you could with a pump. I do think, the pump has certain advantages, and then there are certain drawbacks to wearing one.
Well, listen, once you see the data, in my opinion, then you're going to want a pump. You're going to just be like, oh, I would love to use an extended bolus here, or a temp basal.
Yes. There's that. Absolutely. But you mentioned earlier about some of your listeners being interested in those that technology. And it's funny because, so there are 3 people, that I know from high school that we all have type 1. Only one did at the time. 2 of us got diagnosed as adults. And, I won't name her, but, she has done very well. She was diagnosed in her mid-30s, very well, just when she was on blood glucose meter and injections.
Okay.
A1C in the low 6s. She's very athletic. But she did, I I talked to her a couple times, and I told her what I did, but I'm like, hey, you're doing great, man. Enjoy that. Like you've got good results. There's not necessarily a need to do anything. But then, I think some things changed a little, and she got onto the Abbott Libre, and she's like, wow, this is so much easier than I thought it would be. And I didn't realize, like, it's kind of cool seeing my body, the way it reacts to certain foods. Mm-hmm. I'm like, yeah, well, that's the benefit of CGM. And now, she's like an advocate. But not everyone needs the technology at that point in time, but there's no doubt that a technology like CGM can absolutely give you insights and help make things easier and more, and help you do a better job of controlling.
Right.
She's now a convert. So, that's why we're getting up into this. I don't know, I think the estimates are about 35 to 40% of type 1s might be on CGM.
It's getting there. It really
somewhere
is
at that level. Yeah. It depends what denominator you use. I use 1.6 million. But some people use different numbers. I think that's pretty close. That's what CDC came out with recently. So
yeah, no, I hear you. I think it's, I mean, honestly, you'd be hard pressed to see the data coming back. Like when I make an ad for Dexcom, it makes itself. Data comes back. You get to see what the insulin impacted, what it didn't, how you can next time do a little sooner, a little later, a little more, a little less, do things like I talk about, there's sometimes people have meals. They're like, no matter what I do, if I put too much insulin up front, I just get low later. And so we start talking about bigger ideas like getting the insulin up front through a bolus, an extended bolus, or even a temp basal increase to really force the insulin on the place you need it, and then create I call it a black hole of basal later. Just make a void of basal later so that when the harsh bolus you made tails, it tails right into a black hole where there's no basal, and then that tail just acts as the basal instead of a catalyst to drop your blood sugar. And it's not as hard as it sounds. Do you know what I mean? So if you talk it through a couple times and understand the timing that your insulin hits in, you can create those sort of, those really kind of what feel like advanced ideas. I couldn't do that without a CGM. You think I figured that out before Arden had a Dexcom? You're out of your mind. So,
Yeah. No, that whole concept of the super bolus, right? That was the concept in pumping a while ago, that much better now when you have CGM combined with it, that, if you're high right now, you could take even more bolus and turn your basal off and get that to try to really bring this thing down faster.
Right.
And then, like you said, when it's coming down, it's some of it's replacing the basal deficit. And so you get that softer landing. And so these different ideas, because there's a danger element to it. It's not something you enter into lightly, because if you overdo it, you could have a bad low. But how nice to have a warning system and alarms go off if you are coming down fast and you are cutting below a threshold.
Yeah.
That was the early stage of CGM, just having that alarm. I'm one of those people that doesn't wake up all the time when my alarm goes off in the middle of the night, which is why Control IQ has helped on the overnight. Mm-hmm. But that early experience of finally, having something that's an early warning system, immensely helpful. Right. And so if people are fear of hypo, I'd say, well, CGM can be unbelievable in that regard. Now, you have to be okay and realize you're going to have some alarms, and those alarms can be annoying at times. But it's kind of a necessary evil. I'd much rather have an alarm than wake up in profusely sweating, and anxious,
in a panic, not know what's going on, and hoping you do the right thing and that you don't fall back asleep before you figure out if you're okay, and all the other things that
don't trip down the stairs as you're going because you're a little off balance, and just all those things. Like you realize the way we were acting when the technology wasn't as advanced, that let's take advantage of technology making my life better and simpler.
Oh yeah, you only have to find one person who's had diabetes for 20 years to tell you a story about the time they woke up in the morning and it looked like a bear attacked their kitchen, and they don't have any recollection of it whatsoever. You start thinking you're going to call the cops, somebody's broken into your house, but that was just you looking for frosting. It's an interesting. It's a really interesting. David, I have to tell you, I mean this genuinely. You would love this podcast. Hearing you talk, it was interesting for me because I don't come through academia and I don't have type 1 diabetes, right? I had a daughter. She got diabetes when she was 2. I was immediately the person who was, with her constantly. 2 years into it, I was just still a wreck and everything wasn't going right. And I really felt like I was killing her most of the time. I had started a blog in 2007, the very beginning of 2007, which sounds cute now, but there were only maybe 3 diabetes blogs then. And I wrote about diabetes for such a long time. And then kind of luckily, I guess, I wrote a book about something different. And during my PR tour, of all people, Katie Couric told me I was good at communicating with people verbally. And I just had assumed that everyone was good at that. But she stopped me and told me, no, she's like, you're really interactive. You're moving these people. Like, don't you see, like, the way you're talking, they're following along with you. And it was such a nice thing she said to me. About a year later, when blogging seemed to kind of tail away and it wasn't the thing anymore, people didn't like to read, I guess. I didn't want to lose the impact that I was seeing myself have on other people's lives with type 1 through the blog. And so I started this podcast, which is now 240 episodes or 340 episodes deep.
Wow.
It's crazy, right? And so when I start talking about what I was blogging about, I realized I could explain it. And then I was getting feedback from people and they're like, hey, my A1C is dropping from listening to the podcast. And it built and built. And then suddenly I realized that I had a system, that I had developed an actual system for managing diabetes that I didn't even realize was a system. So I kept distilling it down into t-shirt slogans like more insulin, be bold, pre-bolus, like just little stuff, like just right down to the basic concepts. And what used to be an email or 2 a month through the blog, like, hey, this blog's really helpful to me. It's now become about a half a dozen notes through different like emails and social media a day. Hey, I just wanted to share with you, my A1C came down a point. My A1C is down 2 points. My variabilities, like I just had a guy the other day show me his standard deviation was like 22 from the podcast, which is it's just crazy, right? Like I can't get my daughter to 22. Yeah. I don't know how he did it. It's amazing. And seeing that this was the way, that it's repetition, even though it's not your repetition. Someone comes in, talks about diabetes. I interject a little bit with what I would do there. They tell a story that makes you more comfortable that diabetes is normal. You hear different ways of managing ideas. Suddenly you start seeing, reflections of your own life in these conversations. You make little adjustments, and before you know it, your life's different. And that was not my intention. I just didn't want to lose my blog. Like that was really it. And that it's turned into what it is, it fascinates me because the truth is that it's elevated my understanding of diabetes. This podcast is much more helpful to me than it is to the people listening to it, I guess is my point. And I've gotten to the point where I've spoken about it so much and broken down so many people's lives with type 1 that, I have experiences where I go to, JDRF events and speak, and 3 days later, someone's sending me a 24-hour graph that's never over 120 and never under 70. And they're like, there's ice cream in here. Can you find it? I'm like, no, I don't see it. And not that everyone needs to live like that. And I don't mean to say that my daughter's blood sugar is always 85, because it's not. We're just very reactive to spikes, and we're able to get them down without creating a low. But the point is that it's there for people, and it works. And to have you come on, and I mean this with reverence, I really do, to have you come on, and you don't know me, I don't prep for these things. So 5 minutes before you and I started talking, I had no idea about you. I jumped onto your bio real quick and I was like, I went to Princeton and Penn. Oh, this will be fun. And for you to say things that so closely mimic the stuff that we talk about on the podcast, it made me feel good. Like it really did. Like it made, good's not the right word. It made me comfortable, because there are times where you're saying, like, anecdotally, I saw this thing, and you're saying it out loud. And, when you're blogging to a couple hundred people or 1,000 people, which, at some point it became 1 million people, the stakes are higher, and you realize your responsibility in it. And this podcast has almost 2 million downloads. And so, like you start realizing, like, I'm saying something, I better say it right, and it better be universal.
Yeah.
And so anyway,
well, interestingly, I mean, I'm proud of my Ivy League degrees, but they really
don't help with this.
Have nothing to do with my diabetes knowledge. And I would tell people when I got to Animas, I didn't know that much. I knew basics of type 1 diabetes, and as someone I'd read articles about new products coming out and whatnot. But I had to do research to get up to speed, and like I would go to these conferences and just go to the poster sections where all the clinical research are outlined. And it's like, I mean, ridiculous, hundreds and hundreds of yards of posters, on different aspects of diabetes. And you could just spend all day in there reading them. And I immersed myself to understand things because I wanted to feel like I was very knowledgeable, since I was making decisions about what product we go with next and what features should be in that product. But I learned so much from talking to people who have been dealing with it, and the power of experience and cause and effect, and like being able to figure out what you can use from what someone did. And, some people, like you said, with coffee have different experiences and reactions to it. And that's something, just knowing that that's the case and that you can't just jump on something because one person told you, that's also an important thing. But when someone has gone and talked to a bunch of people and then curated that and given you a perspective, that's where it's valuable. So that's the role I would play. I used to get frustrated. Like people would say, "Oh, what do people with diabetes think about this? Dave, what do they think?" Mm-hmm. As if not asking me because I surveyed 1,500 Animas users.
Because you have it.
But asking me because I was Dave Walton with type 1.
Right.
And that type of thing, happened a fair amount.
Yeah.
So,
no, I hear you. I don't pretend that everyone's life is the same. I don't think that. I just think there are basic tenets about how insulin works. And I think that there are a lot of similarities to people's lives. Like, for instance, one thing I tell people all the time, like, well, how am I ever going to know how to bolus for all these meals? Because we don't count carbs. So we bolus historically. And how do you learn how to do that? Well, some of the truth of that is you don't really eat that many different things. You know what I mean? Like you maybe have 10 favorite meals, or, it's not like one day you're having, truffles and the next day you're having chicken and the third day you're, you just eat what you eat. And so I started telling people like, look, you can look at that plate and say, I don't care what the carb count says. This serving is, the outcome of this meal taught me that while my pump said this was 5 units, it was really 7. If I come around and make this meal next week and don't put 7 units in, I'm an idiot. I don't just, why would I count the carbs again and go, 5 units, just like last time? Like it didn't work last time. And
absolutely. My diabetes educator at the Penn Hospital when I was diagnosed said after the carb counting lesson, eventually you'll probably get to a point where you don't do the calculation. You just immediately gravitate to the end. You go to the end result, which is this food means, this granola bar means 2.5 units or what have you. It's not that you're just going to jump to that and know that association and not go through the math directly. And so like I see pepperoni pizza, which I don't eat that often, but when I do, it's 3.5 units a slice. With a combo bolus, which is what or extended bolus, 60% up front, 40% later, done over about 2.5 to 3 hours.
Right.
And that's how pepperoni pizza works for me. If it's the right size, not too thick a crust, whatever. When it deviates from that, I'll be a little bit off. But generally speaking, I go right into it. It's pepperoni pizza. Here's what I do.
And if it goes wrong, you're not flummoxed.
No, exactly.
You don't spend the next 6 hours. Yeah.
Right. Then I'll monitor and say, wait, with my insulin, do I need to give a little extra? Was I a little under? Was this a little heavier in carb than I thought? Absolutely, all the time. Chinese food you mentioned. The pizza and Chinese food were two of the problem foods for a lot of people, two usual suspects. And the Chinese, I never eat the rice, but man, it's the sauces and any kind of, breading. They put it on certain things. But I try to be mindful of that, and I swear I still always get it wrong.
Yeah. Well, it gets in there with the fat, man, and it just stretches out over hours and hours.
And if you see that stuff in the refrigerator, and the next day you realize how much fat is in the cornstarch or this whatever's in there to make it taste good. It's this big Jello.
It just congeals in a container,
wiggling in the refrigerator. You realize that's what the chicken egg foo young was.
Yes. I have to tell you, last night we were finished, and my wife's like, "Here, put this away," and I'm like, "Throw it away." And she goes, "What?" I'm like, "You're gonna keep that?" And I was like, "Yeah. I mean, I'm not eating it again, just so you know." Like the heat was the only thing making it palatable.
Yeah.
Anyway, David, yeah. I've learned I could talk to you forever, and I've kept you much longer than I told you were going to be on. Here's a funny thing. Did we finish what you wanted to say about what T1D Exchange is doing for people with COVID-19?
Well, no, we talked about COVID. I think the last thing I'll wrap it up with is that, so we are going to be presenting results along the way. So think of it as the cases come in, we analyze them. So yeah, the first 25 cases, we started to do some analysis, draw some, just to characterize, here's kind of what we're seeing, but you can't really draw too many conclusions from the first 25. Mm-hmm. But we'll be communicating this information out on regular basis. So I think by the end of like the first week in May, will probably be the first time we just talk about that. But we've got 60 cases in now. We'll have 100 in 2 weeks. And then there's going to be a lot more. It'll be growing. And we're working with the researchers, these clinicians, Todd Alonso at the Barbara Davis Center in Colorado. It's a big, one of the biggest in the country in terms of taking care of people with type 1. And Mary Pat Gallagher at NYU. They're kind of leading the research along with this Dr. Osagie Ebikosian, who's at T1D Exchange. And he has a wife with type 1. He has got a lot of great experience working in the type 2 diabetes and HIV arenas before he came to us as a consultant and then as a full-time doctor or researcher. So those results will be coming forth. We are talking about additional studies. There's a lot of interest. And I talked about the hospital. We may do something looking at just hospitalizations because of some data that this other company has, and they want to work with us potentially. But there are other aspects of what we've done. So that's our big focus now with COVID. But in general, this collaborative we have, we're focused on improving care. And we work collaboratively with leading diabetes centers, and we're growing that. And so we'll be at over 20 centers that do this regularly with us, picking out topics like how do you drive CGM uptake? How do you screen for depression more consistently?
Right.
Because these things impact care. And our collaborative, we help do the data analysis and share it with them and work with them hand in hand on how can we get us all to a better spot. And we're all collectively focused on let's get people in better outcomes with type 1 diabetes. That's our mission. That's their mission. They just happen to be providers of care at diabetes centers, and we happen to be a not-for-profit in Boston that works with them and does a lot of data and research as part of it. So I love working at T1D Exchange, and I think we have gotten more focused on near-term impact and near-term how can we help other organizations, and whether that's a healthcare system or another not-for-profit improve the situation for people living with type 1. And I think we've had some good progress this year, and more people are interested in joining this collaborative, more centers, and we want to get that bigger so the knowledge gets shared amongst all of them. And we don't have situations where, like I was describing, I'm on the wrong insulin dosing ratios for 10 years. And that was such a simple fix to take off, at least 0.5%, if maybe probably more like 0.7% off my A1C.
Right.
That those kind of things should be done more routinely. And again, we work with some great centers that do a lot of great things consistently, but part of their interest in the collaborative is they're learning from the others. And so they may have a lot of people using CGM, but they may not be screening people for depression and realizing, wow, so that's how you guys are doing it with your medical record system, and how you're getting counselors and social workers connected with patients so that they can deal with these tough problems and challenges. Like, oh, okay. And so it's witnessing it it's awesome.
How do you take, once you learn something from, you gather the data and you sit down and you make sense of it, and you find something that's fallen through the cracks. How do you put it into practice? Because that's really, you know what I mean?
Great question.
Yeah.
And I'll tell you, so I won't go deep into quality improvement methodology because that'll cause some snoozing potentially with some listeners, but there are things called change packages that we helped create working with the diabetes center. So it's kind of like an implementation plan on here's how you do this now. So like we know with CGM usage, look, there are things you can do to make it easier to start someone on CGM. There are also things you can do to make sure that the reimbursement exists. So in Texas, the Texas Children's Center that we work with, they've done a lot of great things to drive up CGM use, but Medicaid wasn't paying for reimbursing CGM for people with type 1.
Right.
And they've actually, I think, been pretty successful in working with Medicaid to get one-off approvals and maybe get a system-wide kind of change for that reimbursement. Well, by sharing some information and approaches used by other centers in other states, that helped their cause, but they took a kind of a leadership thing, like they recognized the importance of it, and we help support them with data. We have a portal that we provide that they can do some reporting themselves and look at things, but we also do analysis and provide them with things. So, but the idea is there are these change packages that we help roll out. That's like the implementation plan to do it. And then there's measurement, and every month you can see how things are going. So are you seeing the CGM usage going up? Just like they look at A1C, we have several years worth of A1C values for all type 1 patients at these centers. They can see what's happening there. They can see what's happening in their high risk group of people with a A1C of 9 or above. And so by tracking it and really, you can't manage what you don't measure. And unfortunately, we've lived through that as a country with COVID.
Yeah.
Diabetes is the perfect example of that. When you do a good job of measuring it, it really helps to manage it. And that's something that we help drive that change with these centers, working kind of hand in hand. And, we're lucky to have a great starting set of centers, and we're looking to add a lot more so we can have a bigger impact. So, 1.6 million people, we've only got about 25,000 patients so far in our system, the data from those EMR, those centers. We're hoping to, drive that number up over the next couple of years, so we have a much bigger sample to work with, and and we're touching more people at those centers, and then other people can learn from that. We'll put publications out. A lot of the researchers that work with us at these centers are putting abstracts out at the ADA conference, European conferences, trying to even share it, learn from people, in Europe and elsewhere. So there's so much that can be done on that knowledge sharing and getting it into the hands of, working with organizations like ADA and ADCES, the new diabetes educator name, and then patient organizations too. Like, we like to get the word out there. And so we've had good work with JDRF and Beyond Type 1 and TCOYD and Children with Diabetes. A lot of great organizations there. And we're all trying to figure out how to help each other kind of just complement each other, not overlap too much. And that's a big part of what we're doing too.
Well, I'm really pleased that you came here to share it with me. So yeah. I appreciate it. Thank you for coming on. I know I kept you long. To find out more about T1D Exchange, you can go to t1dexchange.org. Huge thanks to David for coming on and sharing. I'm pretty confident he's going to be back at some point. I really enjoyed speaking with him. I want to thank also the Contour Next One blood glucose meter. Of course, more information about that can be found at contournext1.com. There's links in the show notes. Touched by Type 1 is at touchedbytype1.org. Please go check them out. Dexcom.com/juicebox for more information and how to get started with the Dexcom G6 continuous glucose monitor. And of course, a absolutely free, no obligation demo of the Omnipod tubeless insulin pump can be sent directly to your door by going to myomnipod.com/juicebox. Have a great day.